only under the Italian sun. This is not true, because if you fly from Italy to India, the results are quite the same. You can see in this real-world study in India, the long-term use of albumin was capable to better control ascites, hepatic encephalopathy, SBP, infection other than SBP, HRS-AKI. Let me go now to patients with recurrent or refractory ascites. What we have? An Indian controlled clinical trial showing that the long-term use of albumin is capable to reduce mortality. Another Indian controlled clinical trial showing that the combination of the long-term use of albumin plus midodrine is capable to improve survival at 6 months. Again, these are controlled clinical trials. What about the real-world evidence? This is our Italian perspective study in 70 patients with the real refractory ascites. We use 40 grams of albumin every week, and you can see that we were able to reduce mortality, to reduce the hospital readmission for any complication of the liver disease, hepatic encephalopathy, ascites, SBP, HRS-AKI, with only one exception, varicose bleeding. Now, this is another Indian real-world study showing that the combination of the long-term use of albumin plus midodrine in patients with refractory ascites is capable to improve survival. Let me say that when we use albumin in the long term, we think that the molecule is exerting not only its well-known oncotic properties, but several non-oncotic properties. Albumin is the most powerful antioxidant agent that we have in the extracellular fluid. But let me focus on the anti-inflammatory action of albumin. Why? Because inflammation is a powerful driver of decompensation. Inflammation is still there in patients with grade 1 ascites, and the level of inflammation rises progressively, moving to patients with grade 2, grade 3 ascites, and overall moving to patients with difficult to treat ascites. Inflammation is the most powerful driver of further decompensation. Now, going back to the molecule of albumin, albumin is capable to go into the immunocell, leukocyte, mononuclear cell. And into this cell, it is capable to inhibit the production and the release of pro-inflammatory cytokine. This makes it possible to reduce the level of inflammation into the organ, like the heart, as you can see. This makes it possible to block some dangerous pathways, such as the overproduction of nitric oxide into the organ, like in the heart, as you can see. And this makes it possible to recover the organ function, like the cardiac contractility, as you can see in this slide. This is not possible if you use any other type of our plasma expander. Let me go now to patients with acute decompensation. We are speaking about patients with the highest level of systemic inflammation. So if we want to control inflammation in patients with acute decompensation, we should use a very high dose of albumin, 1.5 grams per kilo of body weight. With this dose, it is possible to reduce inflammation into the organ and to recover the organ function, such as the cardiac contractility in patients with acute decompensation. So I want to invite you to the next EASL meeting next month in Amsterdam, because we will present the result of the Preciosa study. We use the high dose of albumin in patients with acute decompensation, and the main endpoint was to improve survival at 1 year. Of course, this is a late-breaking abstract. It is under embargo. I cannot show you the result nowadays. I can only say with honesty that we failed to get the main endpoint. We failed to improve survival at 1 year, but we will present very solid data on survival at 3 and 6 months. Well, albumin is a marvel molecule, but is not a magic potion. So if you want to get the result with the long-term use of albumin, you should follow 2 simple rules. The first one is to give enough albumin. How much? To fill the gap between the level of albumin in your patient and the normal level of albumin, close to 4 grams DL. If you try to reduce the dose of albumin and you are not able to get an increase of the serum albumin level in your patient, you will fail on the clinical grounds. You will not be able to reduce the rate of complication. You will not be able to improve survival. The second rule is to give albumin for enough time. How long? At least 2-3 months. If you use albumin only for 1 week, 2 weeks, or for the length of hospitalization, you will fail again. It does not make sense at all. Finally, while acting, albumin deteriorates. What does it mean? Several post-transcriptional changes, sulfonylation, cysteinylation, truncation of the molecule at the N-terminal or C-terminal, and several changes at the same time. The final result will be a reduction of the native albumin, the biological powerful molecule. You can see that the level of the native albumin is decreasing progressively during the course of the liver disease. The lower level of native albumin, the lower probability of your patient to survive at 1 year. So these are my take-home messages. The pathophysiology of decompensation is much more complex than the simple increase in portal hypertension. The most powerful driver of further decompensation is inflammation. The long-term use of albumin in patients with responsive and refractory ascites is capable to improve survival, to improve quality of life, preventing further decompensation, acute decompensation, and ACLF. So I don't know if you can see the tiger on the back. This is my head under a blanket. This is the head of Patrick Ama, and thank you very much for your attention.
Thank you very much.
The albumin is as difficult to see as the tiger, is it?
Thank you so much, Dr. Paolangeli. The next one is a video presentation. I'll just give a brief introduction to the speaker, and then we'll play the video. So this is Professor Sainer, and he works at King Faisal Specialized Hospital and Research Center, Organ Transplant Center and Excellence in Riyadh, Saudi Arabia. His clinical and scientific interests focus on perioperative care for patients with acute and chronic liver failure and end-stage liver disease requiring liver transplantation. His current interests are in determining the causes of hemodynamic instability during liver transplantation, coagulation disorder in end-stage liver disease, and infection in post-liver transplantation. Can we have the video on, please?
Dear colleagues and friends, first of all, I would like to thank the organizers for inviting me for this nice meeting here. Unfortunately, I could not come in person to you. However, I'm happy to present this as a pre-recording. For this lecture, I don't have any disclosures. Just to remind you, patients with acute liver failure experience this syndrome or this illness without pre-existing liver disease. In contrast to that, patients with acute on-chronic liver failure have a pre-existing disease, and when they experience any complications like an operation, trauma, or burning, the liver function deteriorated there, and after recovery, it doesn't reach the pre-existing function of the liver, and these patients most likely requires a transplantation after a certain of time. So how we define acute liver failure? Acute liver failure is defined as a sudden loss of hepatic function, non-pre-existing liver disease, we have elevated liver enzymes as a sign of hepatocellular damage, an ENR above 1.5, and jaundice and hepatic encephalopathy. Beside that, the European Association Study of the Liver Disease stratified these patients in acute liver injury and acute liver failure. Patients with acute liver failure are patients with an acute liver injury plus an hepatic encephalopathy. And the decision for injury and failure is done because it is assumed that patients with acute liver injury, which don't lost their cerebral function, that they have a higher likelihood to recover and don't need a transplantation. Well, when it comes to etiology, acute liver failure, we have different etiologies. We have viral causes, we have toxic causes like paracetamol and phenylprocomone, and we have other causes in between them, acute Buchieri or Wilson, and autoimmune hepatitis is the most likely one of them. However, even if you even put you many attention on how to diagnose an acute liver failure, about 20 to 30% of the cases could not be resolved, and we don't know why this patient suffers from acute liver failure. Regarding the etiology, we have to recognize that the east and west part of the world has different etiologies for acute liver failure. When in North America or in Europe, we have most likely a drug-induced liver injury like phenylprocomone or acetaminophen is the main cause of acute liver failure. Where in Asia we found more viral hepatitis, where in Japan still mainly is hepatitis B, where in countries like India or in China or in Bangladesh we saw most times hepatitis E. In the recent 20 years, different specific treatment modalities were developed for treatment of patients with acute liver failure. First of all, for acetaminophen, we can apply the patient N-acetylcysteine, which serves as a S donor, a sulfur donor for the glutathione. Glutathione is required for detoxification of acetaminophen. We can give an acute hepatitis B, we can apply the patient tenofovir and entecavir. Autoimmune hepatitis, we can give the patient prednisone. Buchieri syndrome, TIPS procedure, pregnancy, fatty liver acid, or HELP syndrome, we have to be ZECTO, or if it's additionally complicated by TMA, by thrombotic microangiopathy, we need also plasmapheresis then. And for mushroom poisoning, we can use a charcoal filter, or we can use a zilibinin, which can IV, which sometimes can prevent the toxic effect of the mushroom to the liver. Well, since we saw some positive effects of N-acetylcysteine in acetaminophen liver failure, several reports came up with the statement that N-acetylcysteine is also beneficial for patients with acute liver failure when it's non-acetamin. Regarding this, Lee and his colleagues performed a prospective randomized trial in 173 patients with acute liver failure, comparing patients receiving N-acetylcysteine and those patients with dextrose. Endpoint was 3 weeks survival, and when we look for the endpoint of overall survival, we don't see any significant difference. The only difference was found in patients with grade 1 and grade 2 hepatic encephalopathy. In these patients, the transplant-free survival was significantly better than in other patients. However, from all this data, from my perspective, these data are not really convincing or not really qualifying to give a general recommendation to use N-acetylcysteine also in non-acetamin liver failure. So there are some. As we know, apoptosis plays a major role in the development of acute liver failure. And from that point of view, it is worth to evaluate a drug which can inhibit this cell death. And this ELF 5755 is a drug which was used as a phase 2 trial in 12 centers in Germany and France. 59 patients participated in the study. 30 patients received a placebo, 29 received the drugs, and the endpoint was the improvement of the ENR. When we look to the whole group, there was no benefit of ENR or survival, and there's only a subgroup of patients who had the hepatitis B and autoimmune hepatitis, a total of 22 patients. They show a significant improvement of ENR. However, we have to say this is only limited data and there's limited number of patients. There's no general recommendation to use these drugs, which is still not approved for acute liver failure. So, as you know, brain edema and acute liver failure is a significant and a prognostic sign. In that point, it's worth to show how we can treat this brain edema. And one of the treatment options was suggested to be with hypothermia. There are some preliminary data from Roger Jalan 20 years ago showing that using hypothermia in this patient cohort, they can significantly reduce the intracranial pressure, particularly during the manipulation during the transplantation of these patients. So this is a prospective randomized trial from King's College. 2 centers from UK and one from Denmark participate in this RCT. The total of 43 patients, 26 patients served as a control. 17 has a moderate hypothermia. What we found was that when it comes to neurologic surrogate parameters like intracranial pressure and cerebral perfusion pressure, there was no difference between the controls and the intervention group, and they saw also no survival benefit. And in one patient, there was a bleeding caused by the intracranial probe. So from this point of view, hypothermia is not indicated or recommended in patients with acute liver failure. So what about the plasma exchange? There was a study published almost 10 years ago. Again, 3 centers, Denmark, UK, and Finland, participated in this study. A total of 183 patients. All patients were listed for an emergency transplantation, and 91 patients was standard medical treatment, 92 was a standard medical treatment plus high volume plasma exchange. And what they show was that we have, with the plasma exchange, a better transplantation